Okay, so let's dive in. Um, and I want to give credit. There are two faculty in our Department of Psychiatry who who developed a presentation on behavioral activation for individuals who don't experience psychosis. And I adapted some of those slides. And so I want to make sure to give them credit, Dr. Patrick Rowley and Carrie Stevens. So our objectives today are to understand the BA model of depressive and psychotic symptoms. We'll just describe how to develop a maintenance formulation or mini case formulation for our client to see how behavioral activation fits in. Understand the role of avoidance in maintaining symptoms. Describe how to help clients select activities and make specific plans, really setting them up for success. And then understand how to evaluate the outcome of their efforts. And then Jeff is also going to talk about some COVID-specific strategies that you can use for clients that have access to technology. And I'll be integrating commentary on how you would make adaptations for clients that don't have access to technology. So it's really important when we're talking about behavioral activation that we're very, very clear about what BA is not. So a common misconception is that behavioral activation is scheduling activities into somebody's day. And activity scheduling is a component of behavioral activation, but behavioral activation as a standalone intervention or as a protocolized treatment begins with an individual's values. And before we can really address, what are somebody's goals, oftentimes we need to do that values exploration, either because the client has never done that work and is not really clear on their values, or because their goals, they either have a hard time identifying goals, or their goals are constantly changing, right? I want to be the king of Prussia one week, and then it's the next week it's I'm getting kicked out of my house, I want my own apartment, and then the next week it's something else entirely. And so it can be very dizzying to the clinicians if we don't have a good handle on values. We're feeling like we're constantly chasing different goals for that person. Values tend to be stable, goals tend to be dynamic. And there's a great video that we played on the group Echo Clinic in the last hour that we'll send you the link to, by Russ Harris, who, for those of you who don't know, he's one of the foremost experts in acceptance and commitment therapy, has written some fantastic books, many of which I have actually suggested to some of my clients. The Happiness Trap and the Confidence Gap are ones that come to mind. And anyway, he has this 3-minute video on the difference between values and goals. And this can be a great place to start with our clients. And this was an adaptation that I made recently for a client that I've just started seeing who has chronic suicidality. And we started to talk about, what are the things that she wants to do, both, what does she want to get out of treatment, but also what does she want her life to look like? And she became very teary with that question, because she didn't see a future for herself. And so it was hard for her to talk about goals. And so I assigned her the Russ Harris video for home practice. We discussed it in the beginning of the session, and then we launched into a values clarification exercise. And there's a lot of different options online that you could do that with. So that's a great place that I would encourage people to start if your clients are having difficulty identifying goals or having a stable set of treatment or recovery goals. And then once you've identified goals, then you can schedule activity. You can start to schedule activities. And the goal of that activity scheduling is really to help the person to create a recovery lifestyle, by which I mean that they are doing the things that matter to them on a daily basis. So these are not just one-off activities that they're doing as a therapeutic exercise. We know that behavioral activation is an evidence-based treatment for depression, it is also best practice for negative symptoms. So we know that CBTP is effective, it is indicated for negative symptoms. Where we tend to see it do best is in two ways. One is if we're targeting social skills, which some people wouldn't even call this CBT for psychosis, but rather social skills training, then that can be really helpful for folks that have some of the affective deficits, that emotional kind of flattening or blunting, or that alogia. And then CBT for psychosis as more of a comprehensive treatment package like we are trained in can be more helpful for that anhedonia type negative symptom. So that low motivation, not connecting with other people, that asociality, and that anhedonia, not expecting to experience pleasure. Behavioral activation works on that set of negative symptoms, that factor, by targeting patterns of avoidance, withdrawal, and inactivity. So you're asking people to start to get active and engaged with others. And it's structured. So we create a weekly plan, and then there's accountability to sticking to that plan. It is brief. It tends to be fairly easy to use, but there's a lot of pitfalls, so we'll talk about those. And it helps people improve their mood, and then it also serves as evidence by which people can start to evaluate their beliefs about themselves, other people, and the world. So critically important that we front load behavioral activation. One, because we know it's going to have mood boosting properties, and if we can boost mood, then oftentimes we'll see that it will have a downstream effect on the psychosis. So even before we start doing some heavier interventions, we can start to get people feeling better by getting them doing more during the day. And then also we're going to use all of that information that they've gathered and kind of treat it like data, and we're going to use it when we start to dive into their unhelpful maladaptive cognitions. Okay, so our three goals, it's very, very simple. Increase adaptive activities, decrease activities that maintain depressive symptoms and psychotic symptoms, both positive and negative symptoms, and then problem solve barriers to engaging in rewarding activities. All of the problems that we have with that behavioral activation and all of the benefits that we get out of it come in one of these three areas. So this is it. This is what we got to do. When we are providing a rationale for behavioral activation, I think it's really important that we recognize, particularly folks that are struggling with negative symptoms, that we recognize that there is a balancing act between activity and convalescence. So one of our models for thinking about negative symptoms is that it is a period of convalescence where the brain is trying to restore itself, particularly after a positive episode of psychosis, which is a neurological assault. And so it's helpful for the person to reduce stimulation. And so they do that, what that looks like is they're staring at a wall all day, right? They're not talking to a lot of people. They're not producing a lot of speech. It's a great effort for them to take a shower. And so we really want to try to help the person have compassion for themselves and practice self-compassion. We want to educate their loved ones to recognize that they're in this period where they're trying to balance these two things so that they can exercise compassion. And then we want to help them to start to re-engage in their community and re-engage in their family and with their life in a way that still, where they still can maintain that balance. So 4 steps. We are transparent in everything we do in CBT. And so our first step is explaining the model so that our clients can get on board with it. And so I'll give you some of the language for that, but you have to tailor it to that person based on their values and their goals. Next, we want to ask questions so that we can start to develop a maintenance formulation and understand how behavioral activation can get factored into that formulation to help the person start to feel better. And I'll give you an example with one of my clients to show you exactly what that might look like. Then we're going to select behavioral activation targets and make a concrete and specific plan. And then we're going to follow up, evaluate how did it go, problem solve barriers, and promote long-term continuation. So this is so important. I don't care if they do the same thing every day, but they should do something in that bucket every day. That something that's meeting that same need. So there are very, very simplistic ways to explain behavioral activation. And oftentimes where I start is, my Nana always used to say, the more you do, the better you feel. And it really is that simple. The nice thing about having that kind of a very quick explanation is that that can become a mantra. Remember, the more you do, the better you feel. It's easy for them to remember. But just sort of a more in-depth explanation here is that we know that when we do less or when we avoid things that make us feel any kind of distress, that in the immediate term, we feel calm or we feel relieved. But in the long term, it often leads to us feeling worse. We feel more demoralized or more anxious, right? And so the idea here is that we want to turn this on its head by having the client do more. And we want to let them know, we recognize that at first it's going to produce some discomfort, right? We're going to ask them to step outside of their comfort zone, but we're doing that in the service of this long-term goal that they're going to feel better. And so when we're stuck in this do less and avoid, we know that this sets the person up for depression, or for depression spiraling into severe depression, or paranoia spiraling into severe paranoia. So we're really trying to pull them out. And oftentimes what we hear from the client is either, I don't feel like it, I'm too depressed to do that, my energy is too low to do those things, or, and I hear this one all the time, I'll do those things when I'm feeling better. And we're actually asking the person to take an outside-in approach rather than waiting for that motivation to come, especially because what's one of our negative symptoms? Amotivation. It's probably not going to come from within. If we wait for it to come from within, then we're going to be waiting a hell of a long time. And by the way, it's actually doing these things that are going to create the recovery that you're waiting for. So we're going to ask people to act according to a plan or a goal rather than a feeling or another internal state. So we want to ask some questions. Always, first and foremost, let's establish a baseline. So let's establish a pre-COVID baseline. What were you doing before all of this stuff went down and everything got shut down? What are you doing now? And that helps you ascertain, are there ways that you can get the person back to what they were doing pre-COVID that are safe, or that can be adapted so that they're safe? And then also, where do you need to think outside of the box, right? Where do you need, like, that's not going to work. They were going to the gym is closed. So what's another way that I could get them engaged in a comparable activity? And then we want to bring in their goal, or excuse me, their values, right? So what were the things that they identified that are important to them, or that would help them to have a more meaningful life? What would their life be like if they weren't experiencing symptoms? I try to avoid using the G word because I think sometimes our clients hear it so much that it's a little aversive for them. So there are lots of other ways to ask those questions without using the word goal. Next, we want to start to develop a mini formulation, or it's also called a maintenance formulation, because we're trying to understand what is maintaining a particular symptom or a particular source of distress. And so again, we can go a very simplistic route, and then we can personalize that to the person. Many people who experience negative symptoms, if you go back to your Kingdon and Turkington about the conceptualization of negative symptoms, a lot of times we see this in sensitivity psychosis for themselves They come from a high functioning family, oftentimes that has high expectations for them, and they do a lot of social comparisons. That person's doing more than me. I'm never going to do as much as they are. Avolition, apathy, but they feel all that. They judge themselves. And so they're going to start to feel guilty, ashamed, worthless, all sorts of distressing feelings. And that then makes them want to do less, which if they act on that urge, perpetuates that cycle. Let's look at that for paranoia. I have paranoia that other people, in the long term, I feel more anxious, so I stay home, and that program relief. So it's a really reinforcing cycle. It's reinforcing something that we don't want to be reinforced. So let's look at this as a maintenance formulation now. So many of you guys might remember a client who I refer to as GBC, generational baby carrier. And she had a lot of paranoid delusions. She had the belief that people were trying to rape her in her sleep, were raping her in her sleep, and were impregnating her with thousands of babies at a time. And then she would start to believe that, she would start to fear for her daughters and her granddaughter's safety as well. And, oftentimes what we see happen is that all of this information, which is probably neutral information, gets misconstrued and gets brought in by the individual as evidence. And before you know it, everything can be evidence, right? Or everything is evidence. So in this case, she came into session, she said, they're going to rape my daughters in their sleep. I said, how do you know that that's, or what led you to believe that that's what was happening? She said, well, I saw the lights of the street lamp flicker outside my room, and they were telling me that they were going to rape my daughters in their sleep. And so what did she do? She did what most of us would have done if we believed that were going to happen. She warned her daughters. She tried to encourage them to stay up. She actually did stay up at night, which obviously didn't help matters. And she stayed home, stayed watchful, on guard. She felt scared and angry, and this really reinforced this belief that this was going to happen, right? Then you get that emotional reasoning. And underlying this was this belief, this core belief that no one needs me, right? Because in her mind, what she was saying is, they need me to protect them. I'm the only one that can protect them. I'm the one who knows that this is going to happen. But we know that oftentimes with these grandiose beliefs, that what underlies them, which often go hand in hand with paranoid beliefs, often what underlies them is this concern that they're not special, they're not important, they are defective, no one loves them. And so that was my formulation about what was happening with GBC for this particular situation. So let me ask you, obviously we know that we can intervene at the cognitive point. We can ask GBC to really go through alternative explanations for the light flickering. We can ask about the evidence. We could do a pro-con of holding on to the sleep, all sorts of cognitive interventions. But if we were to be thinking about behavioral activation, just think to yourself, how might behavioral activation be used to help break this unhelpful cycle? And then hold those ideas, or generate those ideas as I keep talking, because I'm going to get back to this. All right, so let's talk techniques. So we know that in our assessment, we figured out what they're doing now. Before we do anything, that's 4 down here, right? That establish a baseline. Before we do anything else, we need to get that baseline. We then need to get the client on board with this idea, and especially when we have a lot of negative symptoms. And again, remember some of that tendency to judge themselves harshly and to expect that things are not going to turn out well. Then we want to lower the bar for them. So we want to convey this message that the goal here is doing. It is not succeeding. There is no right or wrong way to do this activity. All I want you to do is to do the activity. And it's not forever. It's just an experiment. We're just going to, try it out and see what happens. Now, this all assumes that you've suggested something collaboratively that they're on board with. But I'll get back to that at the end about how do we assess for that. Once you have buy-in and you've got your baseline, then you want to go, let's jump up here to number one. You want to do something together in the session and then bring in a natural support. Now, the natural support can be live. They can join them in the Zoom room from another room. You can give them the link and say you can join at this time. You can do if they're in the house together, obviously just bring them in, which would work by phone or by video conference. So there are ways that you can, in fact, oftentimes what we're seeing is that it's so much easier to engage natural supports now that we're doing more telehealth than it was before. So that's actually going to be a huge asset for you. So bring natural supports in, make sure that they are on board with what's happening and that they can commit to doing that thing too, if that's appropriate. So they're not like reminding the person, which is kind of infantilizing. They are doing it with them because you've gotten them on board with the fact that this could help boost their mood. This could help improve their sleep or make them feel better. And then we want to go low and slow. So we'll talk about, sometimes we didn't realize it, but we actually introduced something that to that client was a Mount Everest, or there was all this hidden meaning to it that we didn't understand. So the activity was that they were going to join a friend group that's now meeting online, but it turns out that the friend group has an ex-boyfriend and, they had all this extra anxiety about seeing their ex again. Okay, get it out on the table and figure out what is doable to them and make sure that you're really going in a very graded fashion. And then reinforce that there's so much about behavioral activation that is dependent on good shaping. So we are shaping behavior over time, which means we're not going to see exactly what we were hoping for right off the bat. And so we need to reinforce every little thing that they do that approximates the goals that we're shooting for, and find out what's reinforcing to them. Maybe it's praise, right? And just giving them, I did virtual high fives. I'm sure I look like a total nerd, but I did virtual high fives with my client the other day, really making sure that we're trying to reinforce, or trying to praise in a way that they find reinforcing. But maybe there are other ways too that you can really get creative about those kind of reinforcements. And one way that we can kind of assess whether like how easy a task might be is to just list some things out. This is a pre-generated activity sheet that obviously came online that would need to be adapted for the COVID age or for your client's circumstances. It would obviously be a little demoralizing if you had things on there that they couldn't afford to do. So make sure that this is appropriate for our time and for their circumstances. And then they could just rate the difficulty level of each of these things, easy, medium, and hard. And there's two ways in which to judge the complexity, right? One is on a practical level, do they have the resources? Do they have the access to make this thing happen? The other is on a psychological level, right? So how hard is it to get to the gym when you haven't been in a long time? I had one client express like the idea of putting on gym clothes in front of other people, which are often more form-fitting than other clothes, was a huge psychological barrier for her. Okay, so we've gone through one. I guess the one thing I didn't touch on with the first goal of behavioral activation is that we always specifically want to be targeting behavioral activation that will target feelings of mastery and self-efficacy, because self-criticism is such a huge problem for our folks. And also pleasure, because we want to target that anhedonia, that expectation that things won't be pleasurable. And the second component is decreasing activities that are maintaining symptoms. So let's just dive into that really quickly. Okay, so here we are back with generational baby carrier, same maintenance formulation. I think I just added something to highlight the hypervigilance here, keeps watch on the street lights. Okay, so let me ask you guys, what kinds of ideas do you have about how behavioral activation might be a helpful intervention for GBC? You guys are gonna have to unmute yourselves. Just jump on in.
I remember you talking a little bit about this at the CBTP training, so I don't want to like cheat and.
No, that is not cheating. That is using what you've learned.
I don't remember if this was like right what you dove into, but I think the longer term goal was to find ways for her to feel like empowered with her family system, so she wasn't having to go to them in crisis. It was like more proactive, like she was going to them, you know, every now and then just to feel helpful or that sort of thing.
Mm-hmm. Right. So what might that look like?
How old were her daughters?
She had grown daughters, and she was living with one of her grown daughters and her daughter's kids.
Was she someone who already left the house, or was she pretty much staying at home a lot?
Yeah, great question. So she didn't have a job, and she was staying home a lot.
So if she's capable, an idea could be that she babysits so her daughter can have a night to herself. Like the daughter might still be in the house maybe at first, but like being able to be alone, and then she could babysit and feel needed that way by
Yeah,
giving her daughter a break.
I love it. I love it. And what I love about it in particular is that it's addressing that underlying belief, right? And so that's exactly what I'm going for. There's so many different ways. I mean, we think about this client, you know, she's got this underlying concern that no one needs her. And, you know, she's at home all day in her daughter's apartment. She's eating her daughter's food. She's watching she's watching cable. And so how can we even start by within her own home, giving her some activities that are going to help her feel more needed. All right. And I think the way that she feels needed now is by warning her daughters, but she also feels ineffective because they're not listening to her and it's actually harming their relationship. And so getting her engaged in some of those activities to start is going to also it's going to get her activated. It's going to get her less focused on the lights and other stimuli that she can incorporate into her beliefs. It's going to boost her mood. It's going to help her sleep better, but it's also going to start to chip away at this core belief that no one needs her. Okay, so then we want to select our BA targets and make a specific plan. So I know I hammered this home, I won't belabor it. The more detailed the plan, the more likely it will be followed. So making sure that you're really drilling down, and people are going to find that to be onerous at first, and it is. But we do the same thing with cognitive restructuring, don't we? We actually have them do that worksheet every time until it becomes so rote that they can do it without. It is so critical for any CBT intervention, but especially for CBT for psychosis, that people are over-learning behavior. So they have to make a very concrete, specific plan so that they're held accountable, they know what's expected of them, and then they need to do that thing over and over and over and over and over again and get feedback on it. So get that plan, make it concrete, and then figure out some ways that you can actually, you know, how is the client going to get reminders during the week? Go for some ways that are old-fashioned, like Post-it notes, and some ways that involve technology, if the person has that, alarms on phones and apps. And then we want to ask those key questions about really 2 questions, right? So how likely is it from 0 to 100 that you'll be able to do this task this week, and then what might get in the way. So those are the two questions. And if the person is identifying that it's below 90%, which is really where what we're shooting for, try to break that task down even more, or figure out what's getting in the way, and let's troubleshoot that. And we talked about that, the practical, complexity of the task versus the psychological complexity of the task, and making sure that our activities are COVID compatible. I'm going to skip through that. And then, okay, final step, evaluating the outcome and problem solving barriers. So if it wasn't first of all, we have to check in on this at the beginning of the session. Tell me how it went, what did you do? And then remember, we're trying to shape the behavior, so reinforce anything that approximated the goal that they had for that week, and then troubleshoot whatever that they didn't do or what didn't go well. And so then figure out what was the issue. Was it that they weren't fully on board with this, in which case you really want to go back and tie it back to their values and goals? Is it that they simply forgot, in which case you're going to go with some very practical strategies? Or was it inadvertently too difficult, even though you asked the right questions? They misjudged it, or they just weren't completely honest about it. Remember, behavioral activation is a starting point. It is not an end point. So we are doing all this behavioral activation is, we're going to find out what's helpful for this person and what's not. And then we want the person to be able to create a routine. And that's a recovery lifestyle, right? I have a routine that gets me out of bed in the morning and keeps me on a schedule. And then once we have those things, I can do the things that I want and need to do each day to live a self-defined, meaningful life. So I'm going to shift this over to Jeff, and Jeff, just let me know at any point. This is actually the last slide, so you can just take it from here.
Yeah, so we thought that it'd be good just to have a bit of a conversation here at the end about adaptations that we need to make for the era that we're living in. So there are a couple of things that we need to consider, and the first is that we have to have the activities that the person's engaging in be appropriate for social distancing and not getting the person sick, or not encouraging them or discouraging them from engaging in activities that would be helpful for them, but making sure that the adaptations that we're making are safe. So that's the first thing that we need to consider. And then the second thing that we need to consider is that if it's not written down, it's probably not going to happen, right? So we know that we've got to somehow get it on a piece of paper, get it to the client in some way where they're going to have some kind of a reminder, something to look at, something to schedule. So that's a really important part of behavioral activation, is that the person has access to the plan and that they have a way of reminding themselves. So we need to consider that we're not going to be sitting there with the client to write a plan down and then give them the worksheets. So that's another thing that we're going to have to think through together, is how we're going to make sure that this important aspect of the intervention is being accomplished, that there's something concrete that the person is getting that's going to provide them with a cue and a reminder to engage in whatever behaviors that they've selected. So we were hoping actually to facilitate a conversation around this, because, obviously there hasn't been a lot of time for us to make adaptations. And I've started us out with just kind of brainstorming it myself around these two issues, and I'm hoping that we can discuss this together. And especially if you've done anything like this with your client, if you could please share examples of ways in which you've shared things, or if you've encouraged your client to make adaptations in their behavior based on social distancing, it would be really terrific to hear actual examples. So in terms of just functionally equivalent behaviors, I think that there's a few things, obviously, that we could do to facilitate this. So if there's some kind of a social goal where the client has access to a computer, camera, some of these kinds of things, or a smartphone, that obviously setting up video conferencing where they're getting social interaction through Zoom or Skype or FaceTime would be one way in which we can make adaptations. In terms of like building skills or doing things for self-mastery, they do have online Skillshare groups. They have online meetups, online book clubs, and there's online community support as well. So there's the online Hearing Voices Network. There's also for folks that have dual diagnosis, there's online support for that as well with NA and AA. So these are some of the things that I found that I think that could be helpful, or that I've known about in the past, but I know that all of you probably have some kind of ideas around this. So I'm just going to open this up for folks to share so that we can kind of get some ideas circulating.